All right, welcome to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a good day. We're coming off a stretch of shifts. Actually had an interesting case, very classical, even though most patients don't fit the usual textbook. And it was elderly female. I guess unique features were that she was not on any immunosuppressive therapy or had immunocompromising conditions. That'll be relevant later. And she came in with that refractory pneumonia. Saw her PCP a couple weeks ago, got antibiotics, didn't get better, came into the hospital. Got broad spectrum antibiotics, still didn't get better, and actually ended up needing the intensive care unit where she had to get intubated. She got ARDS, proning the whole gambit. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. She had like 2 subtle skin lesions that looked really classical for actually blastomycosis, and lo and behold, both blood tests and biopsies of the lesions, she actually had disseminated blastomycosis, so got her on the appropriate therapies now, and hopefully will be doing a little bit better. But nonetheless, that refractory pneumonia, that's failing all these antibiotics, good thorough exam, I'm sure our infectious disease colleagues would agree, can sometimes reveal something you maybe weren't expecting, especially in someone like her who is an immunocompromised and all that jazz. But anyway, today we're going to be talking about beta blocker overdoses. Didn't see any of those on our stretch of shifts, which is probably a good thing. But we're going to go into beta blocker overdoses today. What are beta blockers? We'll talk about classes and properties, formulations. We'll talk about the epidemiology of beta blocker toxicity, mechanism of toxicity, clinical presentation, diagnostic workup, initial ED and ICU management algorithm, including pharmacotherapies to treat it. We'll talk about kind of advanced therapies for it as well, some adjunctive therapies, some kind of advanced hemodynamic therapies, how to monitor, what the prognosis is, and then we'll do a little practice questions at the end. This study guide will be updated on our Patreon page as is usual, so we'd love for you to check that out if you have an interest in getting the study guide. And no further ado, beta blocker toxicity. So most people know this, but we're going to start by what are beta blockers. So beta blockers are commonly prescribed medications. Indications that they're used for are hypertension, ischemic heart disease, arrhythmias, heart failure, migraines at times, essential tremors, thyrotoxicosis. So lots of indications. Most primarily is probably for hypertension, ischemic heart disease, arrhythmias, and heart failure. Those are probably going to be the majority of indications that you see. But lots of patients are on beta blockers, right? Metoprolol, atenolol, carvedilol, all these are beta blockers. There are slightly different classes and properties to beta blockers. So there's the cardioselective beta blockers. These are beta blockers that primarily work on the heart, the beta-1 receptor, hence cardioselective. And these are things like metoprolol, atenolol, and bisoprolol. These are all cardiac selective. And then there's non-selective beta blockers, which work on the beta-1 and beta-2 receptors. So they're not just selective for the heart. And these are things like propranolol, nadolol, and timolol. And then there's some beta blockers that actually have mixed effects, alpha and beta receptors. This can cause some vasodilation from the alpha blockade. And these are things like labetalol and carvedilol. All right, so there's some mixed classes and actions of these beta blockers, and this can become significant in toxicity, although the selectivity is dose-dependent. So in significant toxicities, you sometimes lose this dose-dependent receptor selectivity, and you'll get beta-1, beta-2, alpha, all that kind of stuff. If we're talking about beta blockers, they do a couple different things. Obviously, they'll block these receptors and they can slow down the heart rate and they can optimize myocardial oxygen demand and all that good stuff. But they also have a couple other effects too, and these effects become relevant in toxicity. So one of these is intrinsic sympathomimetic activity. And this essentially means that they may produce less bradycardia in overdose. And these are things like acebutolol and pindolol. These are not common, at least not in the States. I don't know about other places, but just know that they exist. There's membrane stabilizing activity of beta blockers too. The sodium channel blockade, which will become relevant in toxicity as well. And beta blockers that have more of this effect are things like propranolol, again, acebutolol, and betexolol. Propranolol is used. Again, we don't see acebutolol or betexolol very often, but this can lead in toxicity to QRS widening and ventricular arrhythmias because of that sodium channel blockade. Again, we'll talk more about it. And then do note that they're lipophilic. Many of them are, at least. And lipophilic means they're fat-loving, which means it can cross the blood-brain barrier and cause CNS toxicity. Focus on propranolol. You can start to see propranolol's got a lot of these properties that can be dangerous in toxic doses. Metoprolol, which is a very common beta blocker, and carvedilol. So we'll be coming back to these classes and properties as we go through this discussion, because again, this is going to become relevant for some of the symptoms and things we have to do to manage them. As with any toxicity, formulation is incredibly important. You know, we've talked about a couple different toxicity pathodromes, and we have a whole playlist on kind of toxidromes. And for any of you that have seen those, formulation is incredibly important because immediate release is going to act different than extended or delayed release. And the timeline is quite important in these cases, right? If it's immediate release, you're going to have peak absorption of what you took at a certain time, where if it's extended release or delayed release, you might have a much more prolonged toxic period rather than kind of the more expected timeline in someone who took immediate release. So why does this matter? Why are we talking about beta blocker overdose? Well, beta blocker overdose can cause patients to get incredibly ill. This is one of those overdoses that, makes you really, really nervous when you're in the clinical arena, me included, because you can get this rapid cardiovascular collapse, you can get neurotoxicity, and you need to really intervene aggressively and quickly, right? Consider early decontamination, trial something like glucagon, high intensity insulin, vasopressors, bicarb, lipid emulsions, even ECMO, right? All things we'll talk about as we go through this discussion. Okay, epidemiology, just quick. How often does this happen? Well, beta blockers are obviously common among cardiovascular drug overdoses. Propranolol is frequently implicated in severe CNS toxic cases, right? Because as we said, propranolol is lipophilic, it's fat-loving, so it crosses the blood-brain barrier. Mortality increases in these patients with delayed recognition, extended release formulations, co-ingestants. This is one of those other things that for any toxidrome, you need to always think about and ask about co-ingestions because they will affect, 1, the symptoms you're having, 2, how to manage them, and 3, sometimes the absorption of the drug too. And then, so mortality increases with delayed recognition, extended release formulations, co-ingestants, and then any lipophilic or membrane stabilizing agents, right? Lipophilic being crosses the CNS, crosses the blood-brain barrier into the CNS, and MSA agents, things like sodium blockade, which can cause QRS widening and significant arrhythmias. So mechanism of toxicity. Mechanism is important because this will then drive symptoms. So if you understand mechanism, you then can extrapolate and understand symptoms. And as we talked about, beta blockers have beta 1 blockade action, beta 2 blockade action. Some of them have sodium channel blockade action. Some are lipophilic, and then we're going to talk a little bit about a specific beta blocker, sotalol. But beta 1 blockade, beta 1 receptors are in the heart. Right? If anyone saw any of our vasopressor episodes, we talked a lot about the different receptors in the heart and peripheral vasculature. But beta 1 receptors are in the heart, so when you block them, you're going to cause negative inotropy. Inotropy being how good the heart is pumping out blood, how good it's squeezing. So that's going to go down. Negative chronotropy, which is heart rate. So we'll write inotropy is squeeze, chronotropy is heart rate. So both of those are going to go down. And as one can imagine, then you're going to get bradycardic, or low heart rate, you're going to get hypotensive, you can get AV blocks, and you can go into cardiogenic shock. Really serious stuff. Beta blockers, though, if they're non-selective, or even if they're cardioselective and you take high doses, can also have beta 2 blocking effects. All right, and this can cause peripheral vasoconstriction constriction, bronchospasms, and hypoglycemia. We have an episode out on calcium channel blockers, and one of the big challenges is differentiating beta blockade from calcium channel blockade. And the glucose can be quite helpful because in calcium channel blockade, if anyone watched that episode or listened to it, you actually get hyperglycemia. And in the clinical arena, does this always happen? No, but textbook answers and test questions, calcium channel blockers, you'll have hyperglycemia. Beta blockers, you'll have hypoglycemia because you get decrease in glycogenolysis and gluconeogenesis. This is especially common in children. We mentioned that beta blockers can have some sodium channel blockade, and that's going to cause QRS widening. It can cause ventricular arrhythmias, more common with propranolol. Beta blockers that are lipophilic get into the CNS, into the brain, and can cause CNS depression, seizures. Again, propranolol is a big guilty drug for this one, but metoprolol and carvedilol, which are two common ones, can also do this. All right, so you can get some CNS depression, seizures. And then sotalol is non-selective, but it also has this class 3 effect. We've talked about sotalol. We have a whole series on antiarrhythmics, so definitely check that out if you're interested. But sotalol can cause torsades through its QT prolonging pathway. So if we think about the mechanism of toxicity, the 4 main things to think about are beta-1 blockade, beta-2 blockade, sodium channel blockade, and lipophilicity. All right, and beta-1 blockade, you're going to get bradycardia, hypotension, AV blocks, cardiogenic shock. Beta-2 blockade, you're going to get bronchospasm, hypoglycemia. Sodium channel blockade, you're going to get QRS widening, you get ventricular arrhythmias. And if it's a lipophilic beta blocker, it gets into the brain and causes CNS depression, seizures, all that good stuff. So this is then going to translate into clinical presentation. And we break it down by system here: cardiac, neurologic, respiratory, metabolic, and then timeline. So as we mentioned, cardiac, you're going to get beta-1 blockades. You're going to get sinus bradycardia. You're going to get junctional rhythms, AV blocking rhythms. You get hypotension and shock. And then if it's a sodium channel blocking agent, you can get ventricular dysrhythmias. And if it's sotalol, you can get torsades. Okay? Neurologic effects. If it's lipophilic, remember propranolol is a big guilty lipophilic one, as well as metoprolol and carvedilol, which are two common ones. All of these are lipophilic. All of these can get in the brain. So you can get lethargy, coma, seizures, specifically. Respiratory, we also mentioned that beta blockers have beta-2 effects, especially at higher doses, even if they're cardioselective, and then cause bronchospasm. It can even cause apnea. Beta-2 doesn't cause apnea. CNS depression can cause apnea, but you can get bad bronchospasm with the beta-2 blocking effect. Metabolic, remember, hypoglycemia. Calcium channel blockers, hyperglycemia, metabolic hypoglycemia, and you can get a lactic acidosis. The timeline here, remember, is it extended release or is it delayed onset? If it's extended release, the timeline is usually 1 to 2 hours. If it's, did we say that right? If it is immediate release, the timeline is often 1 to 2 hours. If it's extended release, you might have delayed onset, 6 hours, 12 hours plus, sometimes even 24 hours, depending on if there's co-ingestants and things. So immediate release, 1 to 2 hours. Delayed or extended release is just going to be much longer, greater than 6 hours, maybe approaching 24 hours. All right, diagnostic workup. Well, obviously you want these patients to be on continuous cardiac monitoring or telemetry. You want frequent vital signs depending on how bad the ingestion is. You want to get a basic metabolic panel. You need glucoses, right, because you can get hypoglycemia. All this is adding up. As long as we know the mechanism of toxicity, we can extrapolate symptoms and workup. You want to get LFTs, troponin, mag, phos, ABG, VBG, lactate, all that good stuff. You certainly want an EKG, looking for QRS widening, QT prolongation, all that. And then these patients go into cardiogenic shock. So you want to get a chest x-ray. You want to maybe POCUS some, think about pulmonary edema, look to see how their heart's doing, all that good stuff. All right, initial ED and ICU management. Well, with any initial ED or ICU management, step 1 is always going to be stabilize. Do they need to be intubated for severe altered mental status, seizures? Are they protecting their airway? Get some large bore IVs in them. Consider an arterial line. If it's a massive ingestion, low threshold to put an arterial line in, even a central line, right? Especially if the patient's in shock, because these patients most likely are going to keep getting worse if they had presented close after their overdose, rather than better initially. And then treat hypoglycemia. Check a glucose right away. So airway, breathing, circulation, glucose. Recheck frequently if it's low. Decontamination, if this is a really, really recent overdose, they come in within an hour of taking their beta blocker, maybe even 4 hours if it's extended release, you can give activated charcoal, right? This can cause patients to have a lot of GI issues, and as such, airway protection is important to note, because the last thing you want is for to give them activated charcoal and then they aspirate it and it causes all sorts of issues. People talk about whole bowel irrigation. This is not something that we have classically done. So with all of this, we should have said this even earlier, call Poison Center. And you can Google the number in your area. They are an incredible resource. These patients are very sick. Call your Poison Center. They will help you out. All right, first-line pharmacologic measures. Well, if it's symptomatic bradycardia, you can give a dose of atropine, but this is just going to be transient, right? It might not even be effective at all, and this should not delay definitive therapy. So if you want to give a dose of atropine, go for it, but you shouldn't be sitting there banking that the atropine is going to actually be effective or sustained, because it won't be. You can trial glucagon. Realistically, you probably should trial glucagon. This is a bolus usually. If there's no response, you can consider repeating it. You can even do infusions, but this causes a lot of emesis, a lot of vomiting. So really, really, really consider pre-medicating with an antiemetic, and just know they're probably going to vomit. So if you got a patient whose mental status isn't great, they're not intubated, just give them a bunch of glucagon, they might puke and aspirate. So just be really careful with that. Calcium is something people talk about. This is a mainstay of treatment for calcium channel blocker overdose, but the evidence in beta blocker is not super robust. You can try giving it to see if it helps folks. It is kind of like nature's vasopressor inotropes. You might get a little inotropy from the calcium, but much more center stage for calcium channel blocker overdoses. And then, vasopressors and inotropes, are they hypotensive and shock? Do they have low contractility, low inotropy? Are they in cardiogenic shock? Think about epinephrine. Epinephrine has beta 1, beta 2, and alpha effects, so it'll start to overcome some of that beta blockade. Norepinephrine has alpha more than beta effects, so it has less effect on the heart, less kind of increased inotropy and all that. Dopamine is not something we recommend using, although people talk about it. We don't commonly use this, but isoproterenol can increase the heart rate, but it can cause some arrhythmias and hypotension. So, again, we don't classically use it. Really, epinephrine is a great drug in this situation, just because it has both that beta effect as well as that alpha effect. Again, if I'm speaking French and you don't speak French, if this sounds like French to you, check out our vasopressor episodes, because those will provide a lot of context on the different receptors of the different vasopressors. And you can find that on our page, or linked probably in the description of the episode and all that. We got it all over, so just hop on our page and check it out. Okay, advanced therapies. This is where things get a little complex. Just like calcium channel blockers, if you watch that episode or listen to it, high-dose insulin euglycemic therapy is really a central management option for these patients who are getting sicker. And what is literally happening is you're giving high-dose insulin, and the heart then can utilize carbohydrates. It's kind of like turbocharged, and it will cause an increase in contractility for those patients that have failed pressors and glucagon and all that kind of stuff. But notice this is high dose insulin. So this is not medical advice. Please, don't act on this as if it is medical advice. We got disclaimers all over the place. So don't act on these doses or any of that. But just for context, usually this involves a bolus of around 1 unit per kilogram of insulin. That's a ton of insulin, right? Someone's 100 kilos. That is 100 units of insulin bolused. So these patients are going to get hypoglycemic. And we already might be battling hypoglycemia. So you got to give these patients tons of dextrose. Do it ahead of time. Don't be reactionary. People can die from hypoglycemia. So this is really serious. But this is a therapy that you probably will need to do. So you have to be very, very thoughtful in glucose management when you're starting this high dose insulin, because you're going to start then an infusion. This infusion is can be as high as 10 units per kilogram per hour. But usually start at 0.5 to 1 units per kilogram per hour. So this is a very dangerous therapy, but one that can save a patient's life too. And you can do it safely. You just have to be very strategic in your glucose checks, making sure you're giving them extra dextrose as needed and really watching for hypoglycemia. The other thing here is potassium. Insulin shifts potassium intracellularly. So you have to monitor potassium, and if that potassium drops less than 3.5, we would even keep it closer to 4 to 5. If it drops less than 3.5, you really maybe should, depending on the clinical scenario, consider stopping the insulin for a little bit, because someone can obviously die of hypokalemia as well. So hypoglycemia, hypokalemia are two huge things that you need to monitor for and be very aggressive about repleting up front. Additional adjuncts. So if someone has taken one of those sodium channel blocking beta blockers, as we talked about, propranolol is one of them, and you get sodium channel blockade that causes QRS widening, you should give sodium bicarbonate, right? Sodium channel blockade gives sodium bicarbonate, increase the sodium load to try to overcome that sodium channel blockade. So if there's QRS widening, you really should consider giving sodium bicarbonate, 1 to 2 milliequivalents per kilogram bolus. You can titrate it to a pH of 7.5, 7.55, or a QRS that has normalized. And this can be, again, life-saving. You should be very thoughtful about this. If you see QRS widening, that's going to be a risk factor for going to ventricular arrhythmias, so you should be aggressive with your sodium bicarbonate up front. Patients who sees, right, maybe they took a lipophilic beta blocker like propranolol or metoprolol or curvadelol. Benzodiazepines as therapy for seizures is certainly indicated. Some of these patients need to be intubated, propofol, all that kind of stuff. The big thing to note here is that normal anti-epileptic drugs are not very effective in these patients. And if someone has sodium channel blockade, you want to avoid them, especially phenytoin. So treat the seizures with GABAergic medications like benzodiazepines or barbiturates or propranolol, or propofol. Do not give them propranolol. And then avoid kind of those anti-epileptic drugs, phenytoin specifically. If a patient's having bronchospasm, remember we said beta-2 receptors that can cause bronchospasm. So inhaled beta agonists, all that good stuff can be helpful for bronchospastic patients. Not that we've seen a ton of these, but we have seen them, and they're always very, very sick. And bronchospasm isn't something that seems to anecdotally come up very often in these patients, but it certainly can happen. So be observant for it. Some of the other crazy tox stuff, lipid emulsion therapy for refractory shock from a lipophilic agent. So lipid emulsion therapy is literally you're giving intralipid into the bloodstream, and it's kind of these like lipid bubbles sort of. And if you have a beta blocker like propranolol that's lipophilic, the lipid emulsion will kind of surround that propranolol and not let it have any effects on receptors. So propranolol, carvedilol, metoprolol, all those are lipophilic agents. Consider lipid emulsion to treat them. And then if someone's in torsades from sotalol, management's kind of classical, right? Give magnesium. You can consider overdrive pacing, all that good stuff. So these are adjuncts for kind of specific scenarios. And the thoughtful thing here is it a sodium channel blocking beta blocker like propranolol? If so, is there QRS widening? If so, give sodium back, sodium bicarbonate. Are they seizing? Treat them with GABAergic medications. Avoid anti-epileptic drugs. Are they bronchospastic? Treat them for bronchospasm. Inhaled beta agonists. Is it a lipophilic agent like propranolol or curvadelol or metoprolol? Consider lipid emulsion. And then if they're in torsades because they took a bunch of sotalol, magnesium, which is classic. So patients, if they still continue failing these, right? You've tried everything. You've given them pressors and inotropes, and they've gotten their high dose insulin. Maybe you have even trialed glucagon. Maybe they even upfront got activated charcoal. You've given them sodium bicarbonate because it was a sodium channel blocking agent. You've given them lipid emulsion, and they still are failing. And there will be patients, if you practice in a place that's pretty busy with a lot going on and you do it long enough, there will be patients with beta blocker toxicity who fail all of these management therapies because it is such a deadly toxidrome if you take a lot of it. And if that's the case, you have to start thinking about rescue. How can we potentially rescue these patients? You've tried all the tips and tricks. You've been aggressive up front. You should be aggressive up front in big overdoses. Don't be reactionary. Be proactive. Get them on these aggressive therapies early, because if you're reactionary, there's going to be a lot of end organ injury that you're not preventing. Okay, so some of the rescue therapies. Obviously, you can try transvenous pacing for refractory bradycardia, but this sometimes doesn't work because sometimes their heart won't respond to it. So it can be unreliable, but you can try it. The big thing here is VA ECMO, veno-arterial extracorporeal membrane oxygenation. We've done some episodes on VA ECMO as well. Check them out. You can just search Whiteboard Medicine ECMO. That'll probably get it to you. And this is really what can be life-saving for these patients, right? Put them on VA ECMO, let their toxidrome pass, and they will get better. So don't delay this. If you're having trouble managing this patient, they're in fluid cardiogenic shock, you've trying all the things and they're not working. If you're not an ECMO center, get them to an ECMO center. If you are an ECMO center, let your team know. Let the ECMO team know that this might be a patient that needs to be cannulated. Every once in a while, what they took was a dialysable agent. These are ones like atenolol, nadolol, sotalol. So it's not a lot of them, and it's not the most common ones. But if it is a dialysable agent, you can obviously do hemodialysis to try to dialyze it off. This is not effective for propranolol. It's not super effective for many of the beta blockers. It might be somewhat effective for some of them, more effective for others, but it's not really effective for propranolol and some of the other ones. So you can certainly try this, but it might help you, it might not. So monitoring and course. For moderate severe ingestions and all extended release ingestions, just because you don't know how they're going to behave, they should really be admitted to the intensive care unit. These patients, again, aggressive early, right? Trend their lactates, trend their end organ perfusion markers like creatinine and LFTs and troponin and lactic acid. Put an A-line in them, have a central line if you need it. If you're doing high-dose insulin therapy, be checking those glucoses frequently, every 15, 30 minutes, at least every hour. Watch that potassium, serial EKGs, telemetry monitoring, all that good stuff, and really be aggressive up front with these patients. Get ahead of it rather than reacting to decompensations. Prognosis, if you recognize early and you intervene aggressively, there can be some favorable prognosis. Obviously, this is to a degree. If you take too much and you're not in an ECMO center, you might not be able to keep up, but early recognition and early aggressive intervention is key. There are some poor prognostic indicators, as with anything: refractory hypotension, rising lactate, rising acidosis, recurrent dysrhythmias, need for ECMO. All these things suggest a poor prognosis, which probably isn't surprising to anyone. All right, we're getting towards the end here. Here's a quick reference, and we'll do a couple practice questions. Quick reference, especially for test questions and maybe even in the clinical arena. If you're unknown if it's beta blocker, calcium channel blocker overdose, look to the glucose. Beta blockers have hypoglycemia. Calcium channel blockers have hyperglycemia. Hypoglycemia for beta blockers, hyperglycemia for calcium channel blockers. First line therapy, ABCs, right? Classic emergency medicine teaching. If it's early, you can consider activated charcoal. You can consider glucagon, use your pressors. And if they're even showing borderline signs of malperfusion, start high intensity high insulin euglycemic therapy early on, and really titrate it. Watch those glucoses, watch those potassiums. If it's a sodium channel blocking agent, or if you don't even know if it is and the QRS is wide, give them sodium bicarbonate. If they go into torsades, give them magnesium. Consider overdrive pacing. If it's a lipophilic agent or even refractory shock, give them a lipid emulsion. And if you're having trouble keeping up despite this, ECMO. Okay. And always, we cannot say it enough, call your poison center. They will be a hugely helpful resource to you. All right, into a couple practice questions. For those of you who have seen episodes before, you know that we'll read the question, read the answers, and pause quick, and then go read the question, read the possible answers, and then pause quick, and then go into the actual answer. So if you need more time to think about it, just pause the episode, because we'll go into the answer pretty quick. So first question is a beginner question. 27-year-old woman presents 1 hour after ingesting an unknown number of metoprolol tablets following an argument. She's somnolent with a blood pressure of 80/45, heart rate's 38, glucose is 52, SpO2 is 98% on room air. Her electrocardiogram shows sinus bradycardia with a narrow QRS. After securing IV access and giving dextrose, the best next step is to A, start a glucagon bolus, B, administer IV calcium only, C, immediate transvenous pacing as the only therapy, or D, give naloxone and observe. All right, answer is A. So glucagon is a first-line pharmacotherapy for beta blocker overdose. You often are able to improve heart rate and blood pressure a bit. Calcium alone is not effective. Pacing alone is not effective, and naloxone doesn't really address the beta blocker overdose. So next step you would immediately do would be consider glucagon therapy in this patient. Next question, intermediate difficulty. 35-year-old man has a propranolol overdose. Empty 80 milligram extended release bottle found. He's confused. He seizes. His blood pressure is 75/40. Heart rate is 30. Electrocardiogram has a QRS of 160. After airway control and benzodiazepines, which single intervention is most appropriate now? A, give magnesium for torsades. Friendly reminder, they weren't in torsades. B, give sodium bicarbonate bolus and begin epinephrine. C, begin a diltiazem infusion. Hopefully no one chooses that one. D, start hemodialysis. All right, answer is B. Give sodium bicarbonate bolus and then begin epinephrine. So remember, propranolol has sodium channel blocking effects, which means that it'll cause QRS widening, and you treat that with sodium bicarbonate. Give it till the pH is 7.5, 7.55, or narrow QRS. This patient also has hypotension and bradycardia, so epinephrine, right? Epinephrine has both beta effects and alpha effects. Great drug for this toxidrome. So start epinephrine. It gives you some inotropy, some chronotropy, some vasoconstriction. Other options, magnesiums to treat torsades. This patient's not in torsades. Diltiazem would kill this patient. That'd be horrible. Propranolol is not dialyzable. Okay, and remember the patient sees because propranolol is also lipophilic, so crosses the blood-brain barrier and gets into the brain. So other things you can consider here would be intralipid, right? Would be the other thing to consider. But the next step would be sodium bicarbonate and epinephrine. All right, advanced, last question. 62-year-old with ESRD ingests a large amount of atenolol. 12 hours later, he remains hypotensive and bradycardic despite fluids, glucagon, epinephrine, high-dose insulin, calcium, lactate 7, pH of 7.24. What's the next step? A, discontinue insulin due to acidosis. B, start hemodialysis while continuing high-dose insulin and pressors. C, administer lipid emulsion. D, add a third vasopressor and wait. This one's a little bit tougher. Answer is B. Start hemodialysis while continuing high-intensity insulin therapy and pressors. So atenolol is hydrophilic, it's low protein bound, and as such it is dialyzable. So hemodialysis will remove the drug, improve the hemodynamics. You obviously want to continue the insulin and pressors during dialysis till they're doing better. Lipid emulsion is more helpful for lipophilic agents like propranolol and carvedilol, rather than this agent being atenolol. And then stopping insulin and passively adding pressors without source control or any of that kind of stuff doesn't seem like the right thing. So dialyze patients who took a beta blocker that is dialyzable. Today we're going to be talking about calcium channel blocker overdose. We'll be talking about what calcium channel blockers are, just briefly to introduce things. We'll talk about how often it happens, mechanism of toxicity, clinical presentation, diagnostic workup, initial management, advanced therapies, adjunctive therapies, rescue therapies, monitoring prognosis, and then we will get into some practice questions at the end. So we hope this is kind of a high-yield clinical education episode on all things calcium channel blocker overdose. These can be incredibly gnarly. As a friendly reminder, none of this is intended to be acted upon as medical advice. Please listen to the entire episode, and you can see the full disclaimer in the description or at the end of the episode. No further ado, calcium channel blocker overdose. What are calcium channel blockers? Well, I think many of us probably know this, but just to speak it out loud, calcium channel blockers are medications that patients take often to treat hypertension would be one of the main indications. Sometimes angina, right? That chest pain from kind of relative myocardial ischemia. Some patients are on calcium channel blockers for arrhythmias like atrial fibrillation with rapid ventricular response. Some patients take diltiazem. Migraine prophylaxis is another indication, although this one is not super common. The most common that you'll probably see would be for arrhythmias or hypertension, followed by angina, followed by migraine prophylaxis. But lots of patients are on these medications. There are two main classes of calcium channel blockers. Depending on where you're at in your training or post-training, this might be closer in your brain or further away, but they're dihydropyridines and non-dihydropyridines. Since this is not a video on calcium channel blockers, rather calcium channel blocker toxicity, we're not going to dive into the nitty-gritty details on these two separate classes, but we do just want to speak it out loud because, again, it is relevant for the toxicity. So dihydropyridines are potent vasodilators, okay? These have less cardiac suppression, less cardiac activity. So these are often used for hypertension, things like amlodipine, things like nifedipine, again, very common medications. Whereas non-dihydropyridines have greater cardiac effects. They work more on the heart. And because of that, they're more often used for things like arrhythmias. Okay, this is things like diltiazem. All right. We actually wrote them here. Perfect. Yeah, diltiazem and verapamil. These are common as well. People out there might be taking them that are watching this episode right now. But the dihydropyridines are more common than the non-dihydropyridines. The non-dihydropyridines, since they have more cardiac effect, have more negative inotropy, chronotropy, and dromatropy. So this is really a cardiac suppressants. And that makes sense based on what they're used for, right? They're used for things like arrhythmias. So we want to slow the heart down. We want it to squeeze maybe a little bit less. We want it to have less robust contractility, all to kind of suppress that arrhythmia. And as such, they have these greater cardiac effects. So when it comes to toxicity, as one may imagine, depending on which class of calcium channel blocker there's toxicity from, the dihydropyridines like amlodipine or nifedipine, or the non-dihydropyridines like verapamil and diltiazem, you'll have slightly different symptom profiles, although the management is relatively similar. So they are available in both immediate release and sustained release formulations. Anytime we're talking about toxicity from something, it's always important to tease out if it's immediate release or sustained release, because as the names imply, and as one would imagine, these have different kind of timelines in which you will absorb the medication, and the different timelines that you will absorb the medications in can then drive different therapies, and also the type of monitoring you're doing, and also where you might want to disposition that patient if you're in the emergency department, or how often you want to monitor that patient if you're in the inpatient setting. So why does this matter? Well, calcium channel blocker overdoses are highly lethal. Even as an emergency physician and intensivist, these are, these patients who have significant calcium channel blocker overdoses are terrifying. Very, very lethal. Patients get very sick, and they require aggressive therapy in the intensive care unit. All right. Things like high dose insulin that we'll talk about, and sometimes even ECMO, extracorporeal support. So let's dive into it. How often does this happen? What is the epidemiology? Well, calcium channel blockers account for a significant proportion of cardiovascular drug overdoses. All right. They're among the most lethal prescriptions when patients overdose on them. Like we talked about, very lethal, very scary when patients do overdose on these medications. Mortality can be close to 30 to 40% in severe cases despite aggressive therapy, high dose insulin, even ECMO, extracorporeal membrane oxygenation. The mortality is still very high. So these patients are sick. All right. Sustained release formulations are especially dangerous because they have that delayed onset and prolonged toxicity. One may imagine this, right? It's a sustained release formulation, so you're going to have slower release of that drug over time, and as such, you'll get a delayed onset of the manifestations of calcium channel blocker overdoses, and this can prolong the toxic profile. So how do these medications cause toxicity? I think all of us can start to kind of think in general terms about how that can cause toxicity, but what's the actual mechanisms that are at play here? Well, calcium channel blockers, if we think of the name, calcium channel blockers block L-type calcium channels. And they're in the myocardium, or the cells of the heart, the vascular smooth muscle, and actually pancreatic beta cells as well. And this is going to play a role when we think about the difference between beta blocker toxicity and calcium channel blocker toxicity. So remember this little factoid, pancreatic beta cells. But the other two are as expected, heart cells, so the myocardium, and vascular smooth muscle cells. The vascular smooth muscle coats the lining of blood vessels, right? There's all this vascular smooth muscle surrounding blood vessels. And when that vascular smooth muscle either contracts or relaxes, you get vasoconstriction or vasodilation. So if it's blocking calcium channels in vascular smooth muscle, that's going to cause the vasodilation. And if it's blocking calcium channels in myocardial cells, that's going to cause the cardiac suppression. And now we're starting to understand, we're starting to see how the toxicity symptoms we're going to talk about might result from this medication. So if we try to spell it out even further, the effects are cardiac depression, so decreasing contractility of the heart, slowed heart rate or bradycardia, and AV blocks. And as we mentioned, this is especially true of non-dihydropyridines because this has more cardiac effects than non-dihydropyridines like verapamil and diltiazem. So cardiac depression, you also get vasodilation. We just mentioned that smooth muscle relaxes and causes blood vessels to vasodilate, and this can lead to hypotension, low blood pressure, even kind of a distributive shock profile where you get that vasoplegia. Now, I wouldn't think of it like a classic SIRS distributive shock, but you do get that vasoplegia. And then the third thing is metabolic toxicity. We talked about how there's these L-type calcium channels in pancreatic beta cells. And when you inhibit those in pancreatic beta cells, you get inhibition of calcium-dependent insulin release. This then leads to hypoinsulinemia, which then leads to hyperglycemia. So you get increased glucose levels in calcium channel blocker overdoses, which is one of the, at least textbook differences between beta blocker versus calcium channel blocker. And we'll come out with a dedicated episode on the differences between the two, and we'll compare them and all that stuff. But the three main effects then are cardiac depression, vasodilation, and metabolic toxicity, which you can really think of as hyperglycemia. In the severe cases, the cases that keep me up at night, you can get cardiogenic shock, refractory hypotension, metabolic acidosis, multi-organ failure, and this can eventually spiral to death, despite aggressive care. So what does a clinical presentation look like? If we think about what the calcium channel blocker toxicity is doing from a mechanistic standpoint, we can then start to kind of extrapolate that to the clinical presentation. So early on, if it's immediate release, early on is just within a couple hours, 0 to 2 hours. If it's sustained release, you might see that up to 6 or 8 hours. You get general symptoms, dizziness, nausea, vomiting, some mild hypotension. And this progresses into those cardiac depressant effects as well as vasodilatory effects. And you start to get bradycardia, AV blocks, refractory shock. This can lead to altered mental status. You can get seizures, pulmonary edema from the cardiogenic portion of this. In the distinguishing features that represent in textbook questions calcium channel blocker overdose, and these do occur in the clinical arena too, it'd be a combination of profound bradycardia, hypotension, and hyperglycemia. And those are, if you think about kind of 3 textbook symptoms of calcium channel blocker overdose, those would be it. It'd be bradycardia, it'd be hypotension, and it would be hyperglycemia. So remember that for test questions, and again, also the clinical arena. All right, the diagnostic workup here mostly looks at end organ dysfunction. There's no magic, test that directly tests for calcium channel blockers. You have to go based on history alone and then the clinical pathodrome. So diagnostically, you obviously want vitals and a full cardiac workup and put them on telemetry monitoring. And then labs, you want to do a basic metabolic panel, look at the glucose, look at the renal function, get a blood gas, lactic acid, think about acid base, liver function tests, mag level, troponins, glucose, electrocardiogram to look for bradycardia, AV blocks. And then with any toxidrome, and we cannot stress this enough, so the most easily missed toxidrome is the second one. You might have a patient who, their family's like, we saw them take, 100 amlodipine tablets, and you're like, okay, I know this, I got this. It's calcium channel blocker overdose. I listened to that episode on Whiteboard Medicine. I got what's going on here, but you might then miss the co-ingestant, the second intoxicant. So test for co-ingestions. We can send Tylenol levels. We can send salicylate levels. We can send alcohol levels. We can test digoxin levels. And even the things we can't test really push that history to see if there's other medications that the patient may have ingested. Because this can dramatically affect things, ranging from slowing your absorption of that drug and changing the timeline you're monitoring that patient, all the way to creating very complex mixed toxidromes. All right, now we've diagnosed it. We've thought about the mechanism, we thought about why it's happening. What can we actually do for these patients? The initial management, as with kind of all sick patients that come to the hospital starts with stabilization. And it starts with the classic things. Make sure they're protecting their airway, because sometimes they can get so altered that they have trouble with airway protection. Make sure that they have great peripheral IV access. I personally have a very low threshold to put an arterial line in these patients. And then treat any glucose abnormalities. This was a typo. We wrote hypoglycemia, but hyperglycemia is more common in these patients. Decontamination after stabilization is something to consider. You can use activated charcoal if it's within a couple hours of ingestion and you have their airway protected. But if it's after that first couple hours, activated charcoal probably is not something that's going to be effective. All this is going to be guided by your poison center and a possible tox consultation, and obviously your clinical gestalt as well. But we always say, use your poison center, call them. If anyone's like, what's the number? Google it. Literally, poison center, insert your area, and the number will pop up. They're an incredible resource. But within the first couple hours, you can consider activated charcoal. Whole bowel irrigation is something that's discussed specifically for sustained release ingestions. We personally have never done that. Not to say we've had an opportunity to and actively chosen not to. We just haven't been in that situation. But again, it's not something that we would do without guidance from our poison center. After stabilization, after decontamination, your first line therapies are going to be, drumroll, IV calcium. Let's see if we can overcome the receptor blockade. All right, calcium chloride or calcium gluconate, repeat as needed. Sometimes they need a continuous infusion, but calcium to try to overcome the calcium channel blocking, which makes sense. Bridge these patients with vasopressors, norepinephrine or epinephrine for hypotension. Dopamine used to be something people used. We are not a big believer in dopamine for these patients, so use epinephrine if they're bradycardic, norepinephrine if they're hypotensive. You can trial atropine for bradycardia, although it's probably not going to provide any sustained benefit. But if you're in a pinch and you're trying to get a bunch of stuff together, you certainly can trial some atropine for bradycardia. So the first line therapies are going to be calcium to see if you can overcome that calcium channel blockade. Vasopressors, either epinephrine, which can be helpful if they're a little bradycardic, or norepinephrine if it's really a hypotension issue. And you can trial atropine just to bridge them while you're getting everything together, but just know that that's not kind of a sustained solution to what's happening here. Many of these patients with significant overdoses, though, require much more advanced therapies. One of the big ones here is something called high-dose insulin euglycemic therapy, or HIET. And what this is, if you haven't done this or heard of this before, this might sound a little bizarre, but you start the patient on high-dose insulin. And what it actually does is it improves myocardial carbohydrate utilization, and that increases myocardial contractility. Bizarre to think about, but it's true. So high-dose insulin is almost like an inotrope. It improves myocardial contractility through kind of like supercharging the myocardium's ability to utilize carbohydrates. But this is high-dose insulin therapy. This is not to treat hyperglycemia. So these patients, and again, none of this is tend to be acted upon as medical advice, double check doses and things like that. But typically you're bolusing something like 1 unit per kilogram. So this is a ton of insulin, 100 kilo person, it's 100 units, huge amounts. And then you're starting those patients on an infusion, usually 0.5 to 1 units per kilogram per hour. And you can even titrate that up. So these patients are getting huge amounts of insulin. And because of that, hypoglycemia is a really, really, really real risk, and it can kill patients. So you got to be incredibly, incredibly thoughtful about glucose checks, giving them dextrose back. You really want to maintain that glucose 100 to 250. Sometimes I err on the side of closer to 250 just to be safe, and they're gonna need a dextrose infusion. All right, they might need a high concentration dextrose infusion, not just D5, but D10 or D20. All right. You should be checking glucoses really every 15 or 30 minutes just because the hypoglycemia risk is so high. The other thing to always remember is insulin shifts potassium into the cell, right? So hypokalemia is a big risk of this. You want to keep that potassium greater than 3, people say, but really Greater than 4 is a much better target. And they're going to need potassium supplementation. So if someone needs high-dose insulin to try to save their life from a calcium channel blocker overdose, they do. And many of these patients with bad overdoses will require this. But remember, this medication, this high-dose insulin euglycemic therapy, can also kill patients from hypoglycemia and hypokalemia. So we have to be very thoughtful in checking the potassium frequently, supplementing aggressively with potassium, and then also checking the glucose frequently and getting them on high concentration glucose infusions as needed. So you've tried calcium, you've tried vasopressors, you've tried high-dose insulin euglycemic therapy. None of this is working. Adjunctive therapies that you can also give a shot are things like glucagon. Glucagon transiently can lead to more inotropy and chronotropy. This is more commonly used in beta blocker overdose. It probably has a limited effect in calcium channel blocker overdoses. It's not something we commonly use for calcium channel blockers, but you will read about it out there. Intralipid therapy. This is an option for refractory cases, especially if the calcium channel blocker is lipophilic. Philic meaning loving, lipo meaning fat, so fat loving. So intralipid therapy is essentially you give intravenous lipids, and if a medication is lipophilic, if it loves lipids, the intralipid will kind of encapsulate the medication in the bloodstream and lead it to not be able to have its intended effect. So verapamil is a highly lipophilic calcium channel blocker. So patients who are failing initial therapy, if it is a lipophilic calcium channel blocker, you should give that patient intralipid therapy. And then patients just who have profound hypotension, refractory vasoplegia. People talk about the use of methylene blue. We've talked about methylene blue on the channel multiple times before, so definitely check out those episodes if you're interested in that. But methylene blue is something you consider in refractory vasoplegia. When all this is failing, the end-all be-all here is ECMO, extracorporeal membrane oxygenation, VA ECMO, another thing we've talked about on the channel. These patients, if they're sick enough, will require VA ECMO. You can do high-dose insulin therapy. You can do intralipid, methylene blue, vasopressors, calcium, all that stuff. And if the toxidrome is bad enough, if they've taken enough calcium channel blocker, they'll fail all that. And they'll have refractory shock, and they'll need ECMO. And most typically it has to be veno-arterial ECMO. Again, we've talked about ECMO on the channel. Check those out too. You just look up whiteboard medicine and ECMO and it'll pop right up. Same thing with methylene blue and all that other stuff. But these patients sometimes do need ECMO, and that's kind of the rescue therapy. That's where you get towards the end of the road. For refractory bradycardia, you can try temporary pacing. It's not always effective. You might have trouble capturing that beat, and you might have trouble getting capture, and thus you might not be able to pace them, but you can try, right? If a patient's going to die and you're doing everything you can certainly give that a try. So if we were just to summarize the therapies, right? So the first is stabilize, as you would any sick patient that's coming to the hospital. Decontaminate, considered activated charcoal as guided by Poison Center if it's a overdose that you got to quick enough. All right, IV calcium to see if you can overcome the blockade. Vasopressors like epinephrine and norepinephrine as needed. I'm going to put atropine in little parentheses because you can try it, but it's not a solution to what's going on and it might not work. High dose insulin euglycemic therapy. I'm going to put glucagon in parentheses because glucagon you can try, but it probably will not work. Intralipid be the next thing. Methylene blue for refractory vasoplegia. And then if we're getting down there at the end of the day, ECMO. So this is kind of the progression of therapies that you might see here. And this should be the things that you're thinking about, obviously as guided by a toxicology specialist or the Poison Center. So monitoring supportive care. All these patients with significant ingestions have to be admitted to the intensive care unit. Hopefully we've beat things over and over again and demonstrated, if nothing else, that these patients are incredibly sick and many of them die. So they all got to go to the ICU. Continuous cardiac and glucose monitoring, as one might imagine, serial electrolytes, serial glucoses, frequent hemodynamic assessments. All these patients should have an arterial line, at least in our humble opinion. And patients may require days of high-dose insulin therapy, of vasopressors, or even if they end up on something like ECMO. The prognosis for these patients is actually, unfortunately, quite poor for the sickest ones. Patients with refractory hypotension, severe acidosis, lactate greater than 8, requirement for ECMO. All these are very kind of poor prognostic signs. Survivors are often the ones who get aggressive early interventions. So don't sit there and kind of tolerate a little hypotension, a little bradycardia with the thought that your therapy is going to kick in, right? Be aggressive early on. Start these patients on calcium, start them high-dose insulin therapy, give them intralipid, talk to ECMO specialists, all that kind of stuff. Aggressive early interventions are critical if we want to try to save these folks. All right. That's all we have for the main bulk of this episode. We have a quick reference we'll go through and then some practice questions at the end if anyone wants to stick around. Do remember that all these study guides are on our Patreon page, and we'd definitely love for you to check that out. It'll be linked in the description. But quick reference. So the classical clues for calcium channel blocker overdose are bradycardia, hypotension, and hyperglycemia. First-line therapies are IV calcium and vasopressors. Next definitive therapy is high-intensity insulin therapy, and start it early. Remember, early aggressive interventions are key. Adjuncts, you can trial glucagon, you can trial lipid emulsion, you could trial methylene blue, and rescue therapies are ECMO. Always talk to your poison control center. We put a number on here, although we can't guarantee that this is the right number, so actually maybe we'll cross that out. Just Google poison control center with your area, and you'll be able to find the number. So get them involved early. All right, now for some practice questions. The way we structure the practice questions is there will be a beginner, intermediate, advanced. We'll go through the question, we'll go through the possible answers, and then we'll have you pause if you want more time to think about it, because we'll dive right into the answer. So practice question number 1 for beginner. 60-year-old man presents 2 hours after taking an overdose of his diltiazem tablets. He's hypotensive with a blood pressure of 85/50, bradycardic with a heart rate in the 40s, and he's lethargic. His glucose is 220. What is the best next step? A, start IV calcium. B, give naloxone. C, discharge home with observation. Or D, administer IV digoxin. Pause here if you need more time. The correct answer is A, IV calcium. We talked about how calcium is the initial stabilizing therapy. That's the first therapy you're going to be giving to these patients, assuming they don't need decontamination. So naloxone, option B, would be for opiate overdoses. Discharge home would be incredibly dangerous. As we talked about, these patients are very sick. And then administering IV digoxin, this is just a random wrong answer. Digoxin has nothing to do with calcium channel blocker overdoses. All right, question number 2, the intermediate question. A 45-year-old female ingested an unknown amount of amlodipine extended release. She presents 6 hours later with a heart rate of 55, blood pressure 70/40, despite IV fluids, glucose of 180, potassium of 3.5. She's received 2 doses of IV calcium with minimal improvement. What is the most appropriate next step? A, start high-dose insulin euglycemic therapy. B, administer glucagon infusion. C, increase IV fluids aggressively. Or D, discontinue monitoring if stable. All right, pause here if you need more time. The most appropriate next step would be A, start high-dose insulin euglycemic therapy. So we talked about these patients. You trial some fluids, trial some calcium, and if they have persistent shock, we got to be aggressive early. We got to put them on high-dose insulin therapy. Obviously, talking to your poison control center, but the most appropriate next step would be starting that high-dose insulin euglycemic therapy. Option B, administer glucagon infusion. You don't tend to do infusions, and for calcium channel blockers, this isn't that effective, so this would not be the most appropriate next step. This patient's sick. They need a high-dose insulin therapy and maybe even, a call to ECMO and vasopressors and all that jazz too. So that would not be the best answer. Increase IV fluids aggressively. This is not a hypovolemic problem. This is a vasoplegia and cardiac suppressant problem. This patient already received fluids. You're not going to save their smooth muscle relaxation and vasodilation or their decreased cardiac contractility with more fluid, so wouldn't be the best answer either. And then discontinue monitoring if stable, obviously just the wrong answer. So correct answer is A. Last question here, the advanced. A 38-year-old man is in refractory shock 12 hours after a massive verapamil ingestion. He's on norepinephrine at 0.5 micrograms per kilogram per minute and epinephrine at 0.3 micrograms per kilogram per minute, plus calcium, plus high-dose insulin euglycemic therapy at 8 units per kg per hour. Just to speak that out loud, if this person was 100 kilos, 8 units per kilogram per hour would be 800 units per hour. Huge numbers. His lactate's 10, his pH is 7.1, his MAP is 50. What is the best next option? A, add a third vasopressor. B, start IV lipid emulsion and evaluate for VA ECMO. C, stop the insulin therapy. D, administer a large sodium bicarbonate bolus. All right, pause here if you need more time. The correct answer is B. This patient, correct answer is B, start IV lipid emulsion and evaluate for VA ECMO. This patient has refractory shock despite maximal medical therapy. Lipid emulsion could help, but VA ECMO is the salvage therapy here, right? So other options, add a third vasopressor. You certainly can do this, but it would not be the next best step that would help save this patient. Option C, stop insulin therapy. Patient would most likely die. And option D, administer large sodium bicarbonate bolus, would not help this patient. They need ECMO and maybe lipid emulsion as salvage therapy. But there's going to be a direct comparison as these two have a lot of overlap, and both for taking care of patients in the clinical arena as well as tests. Often these two are kind of compared to each other, and there's test questions on how to differentiate them. So that's what I wanted to dive into today. As always, the study guide will be on our Patreon page, linked in the episode description. All of our study guides and practice questions and ad-free videos and all that good stuff are all on there if you want to check it out. No further ado, beta blocker versus calcium channel blocker, quick comparison. So obviously we have beta blocker toxicity on the left side, calcium channel blocker toxicity on the right side. And we're going to go through the differences, starting with mechanism. And this is not going to be as much detail, but it's nice as a quick comparison. So beta blockers obviously are going to block the beta receptor. As we've talked about, there's some sodium channel receptor blocking in certain beta blockers like propranolol. And there's even at times some of them that can cross the blood-brain barrier and cause CNS effect if they're lipophilic. But the primary mechanism is beta blocker receptor activity decrease. And that typically decreases chronotropy, so decreases heart rate. It decreases inotropy, or the squeeze of the heart. It can cause conduction problems, and it can decrease blood pressure too. Okay. Calcium channel blocker toxicity, on the other hand, focuses on these L-type calcium channels. And blocking those are going to decrease the amount of calcium that influxes into your muscles, the myocardium being the heart muscle as a primary muscle affected here. And that's also going to impair cardiac contractility, conduction, and vascular tone. So as you can see, there's a good amount of overlap between the results of beta blocker and calcium channel blocker toxicity, although how they achieve those results are obviously different mechanisms. So the onset of action here for beta blockers is typically rapid. Now, there are extended release versions of beta blockers, right? Brand name Toprolol would be one of those. So this is not a hard and fast rule, but many beta blockers have a rapid onset of action. Calcium channel blockers are a little bit more delayed, and many people take extended release formulations of calcium channel blockers. So calcium channel blocker toxicity comes on a little bit later in general than beta blocker toxicity, although that's obviously very dependent on the beta blocker calcium channel blocker, right? So that we can talk about generalities, but it really depends on which medication it is. Symptoms here, as you're going to see, have a ton of overlap. So beta blockers, bradycardia. Calcium channel blockers, bradycardia. Beta blockers, hypotension. Calcium channel blockers, hypotension. Beta blockers, fatigue and dizziness. Calcium channel blockers, fatigue and dizziness. Now we get into a couple differences. One of the big ones to note is that calcium channel blockers tend to cause hyperglycemia because they inhibit insulin release, whereas beta blockers tend to cause hypoglycemia. So that's one of the big differences, and tests love to test this little factoid. So calcium channel blockers, hyperglycemia. Beta blockers, hypoglycemia. Beta blockers also can cause bronchospasm through the beta 2 receptor that you don't often see with calcium channel blockers. Anecdotally, I don't feel like I see a ton of bronchospasm from beta blocker toxicity, but it can happen, certainly. All right, so that's another difference. So beta blockers, hypoglycemia and bronchospasm. Calcium channel blockers, hyperglycemia, no bronchospasm. And then in both of these, you can get neuro effects, but it depends. So in beta blockers, you can get seizures, coma, mental status, depression, but only with lipophilic or fat-loving beta blockers. Again, things like propranolol. Whereas calcium channel blockers, you can get altered mental status and confusion, but there's not as much, seizures per se in calcium channel blocker overdose as you can get with lipophilic beta blockers like propranolol. All right. If you do have a beta blocker that has sodium channel blocking properties, you can get QRS prolongation that increases your risk for arrhythmias. And again, propranolol is one of those that can do that. And sotalol, being a beta blocker, kind of has its own little pathodrome within the beta blocker context because it has more QT prolonging and risk for something like torsades. But the big differences here would be that the glucose is going to be high, hyperglycemia in calcium channel blockers, and the glucose is going to be low or hypoglycemia in beta blockers. Beta blockers have bronchospasm, calcium channel blockers do not. And beta blockers, if it's a lipophilic beta blocker like propranolol, have more incidence of seizures, whereas calcium channel blockers do not. So what about the clinical symptom or clinical signs that you'll see? Well, these are related, obviously, to some of those symptoms and the mechanism, right? You'll get bradycardia with each of them. You can get AV blocks with each of them. You can get hypotension and cardiogenic shock with each of them. And then we talked about hypoglycemia in beta blockers, hyperglycemia in calcium channel blockers. We talked about bronchospasm in beta blockers, no bronchospasm in calcium channel blockers. And then if you're on something like sotalol, you can get wide QRS. If you're on something like propranolol that has sodium channel blocking, you can get wide QRS. If you're on something like sotalol, you can get prolonged QTC. And you can get metabolic acidosis and severe shock with each of these, although calcium channel blockers maybe have a little more predilection. Pulmonary edema is possible in both of these as well, especially if you're in cardiogenic shock. So when it comes to kind of signs, some of the main ones that can differentiate these are really the glucose and then bronchospasm, because there's a lot of overlap between them otherwise. All right, what about key labs and bedside things? This all comes back to the primary mechanisms. Some of the only key lab differences, like we talked about, hypoglycemia with beta blockers, hyperglycemia with calcium channel blockers. Hopefully that is ingrained in your brain now. And then seizures, if it's a lipophilic beta blocker like propranolol, are more common, and metabolic acidosis is more common in calcium channel blockers. But at the end of the day, that's, not even perfectly applicable, because if someone's in shock, which you can go into cardiogenic shock from beta blocker overdose, you certainly can get a metabolic acidosis there too. So how do we treat these two things? What are the differences in treatment? Well, the main differences here are going to be a couple different medications you could consider. So for both of them, you're going to start by treating with, ABCs, airway, breathing, circulation, get peripheral IVs, fluids if they need it, although if they're in cardiogenic shock, you're not going to be wanting to give them fluids. You can certainly try giving atropine in both of these, but if it does work, which it might not, if it does work, it's going to be transient, so that's certainly not a solution to this. Next, though, in beta blockers, you often start with something like glucagon, which can increase your amount of cyclic AMP that can help, whereas in calcium channel blockers, you do not. In calcium channel blockers, you tend to give calcium to overcome the calcium channel blockade. All right, so that's one of the big differences. In beta blocker toxicity, you're going to trial glucagon. In calcium channel blocker toxicity, you're going to trial calcium. Both of these can benefit from high-dose insulin euglycemic therapy, which we talked a lot about in those original episodes. Both of these can benefit from vasopressors with a particular focus on epinephrine, because epinephrine has both beta and alpha effects, whereas norepinephrine is primarily alpha effects. Both of these can essentially benefit from IV lipid emulsion, but it has to be for lipophilic or fat-loving beta blockers or calcium channel blockers. If someone's sick enough, though, you might just try that in general for all of them. And then all of them, if patients have refractory shock and they're not getting better with your other interventions, might need ECMO. So you can see here, management, which is nice because it's sometimes hard to differentiate between these two toxicities, and management is very similar. Lots of overlap, with one of the key kind of differences is glucagon and beta blockers, calcium and calcium channel blockers. And then again, for treatment in beta blockers, if you do have QRS widening from sodium channel blockade, you're going to be giving something like bicarbonate therapy. All right, and then unique pearls. This is the end. Again, this is just a quick kind of cheat sheet to compare these two unique pearls here. Again, beta blockers, think hypoglycemia, think seizures. That can point more towards beta blockers, whereas calcium channel blockers think more hyperglycemia in calcium channel blockers. In lipophilic beta blockers like propranolol and carvedilol, think CNS depression, and that's where you get some of those seizures. Verapamil tends to cause worse cardiogenic shock than dihydropyridines in the calcium channel blocker varietal, because verapamil and diltiazem are non-dihydropyridines, which mean they have more cardiac effect, as just kind of little pearls here. So when comparing the two, either in the real world or in the test setting, nicely in the real world, therapies overlap significantly, and we talked about a lot early aggressive interventions for these patients. But beta blocker toxicity, you're going to be trying glucagon. Calcium channel blocker toxicity, you're going to be trialing calcium. Clinical things that can differentiate them, especially on the test, would be hyperglycemia for calcium channel blockers, hypoglycemia for beta blockers. Also, calcium channel blockers do not have bronchospasm, if that's included in kind of the test vignette as well. And then in addition to that, if it's a lipophilic or a fat-loving beta blocker, sometimes you see a little more seizure in the beta blocker toxidrome. All right, hopefully that was helpful. Let us know what thoughts, comments, questions you have. We'd love for you to check out our Patreon page, YouTube platform, podcast platform. We would love to buff those up and interact with y'all kind of across multiple different varietals there. So definitely check those out if you have an interest. Either way, nonetheless, stay well, keep learning. We'll see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.